often appear on the test. So the localizing ones you need to know because of the test, but both the localizing and the non-localizing have the same workup, which is you have to do an imaging study, and our imaging study of choice is going to be MRI with contrast, and you're going to be looking at brainstem regardless. It's going to be a posterior fossa MRI, regardless of whether it's localizing, that is, you know where it is, versus not localizing, you don't know where it is. So almost all the forms of nystagmus are non-localizing. So the very first thing you got to do is define the fellow travelers. And what a fellow traveler means is, what are the other features that are associated with that nystagmus that would help you to decide what the cause is? So we have an order of operations. The order is always the same. Talk to the patient, symptom, examine the patient, that's the sign. Then you can scan them, and then you can do the laboratory test in that order. So symptom, sign, scan, serology, and then you can make a diagnosis and solve the problem. So yeah, so we're just going to go through this one first. If you could turn, can we turn that off for a second, so they can see this board? Thank you so much. What was your name again?
Bedder.
What is it?
Bedder.
Bedder?
Yes.
Thank you. Sure. Okay, so the nystagmus that is localizing, luckily they all kind of match, the letters kind of match where the localization is. So who wants to shout out a localizing form of nystagmus? Just name one.
Downbeat.
I don't know your name, so it doesn't
Downbeat.
matter.
Downbeat.
Okay, downbeat, downbeat. So nystagmus is named for the fast phase. So even though the fast phase is what we name it for, that is actually the corrective saccade for the pathologic phase. So the pathologic phase in downbeat is your eyes are trying to drift up, and then you have a corrective saccade down, like this. So the downbeat is the fast phase. So fast down. So that is D, downbeat. It localizes to C, which is, where is the localization? You want to yell it out? Cervical medullary junction. So, and the most common cause is the Chiari malformation. So D, downbeat, cervical medullary junction, C, Chiari malformation. But again, you need to image all of these nystagmus regardless of whether it's localizing or not. But for the test, if the eye is going down, downbeat, fast phase, it's going to be worse when they look right or left. And when they look down, that's called Alexander's law. And downbeat D, cervical medullary junction C. There are other things that cause downbeat, paraneoplastic disease, infectious, inflammatory, demyelinating. But the thing with nystagmus is the cause list is the same. It's the localization that you need to know. Where is the lesion is way more important than what is the lesion for nystagmus. So downbeat D, cervical medullary junction C. You need to think about meds, lithium, antibodies, glutamic acid decarboxylase antibodies, demyelinating disease, infections, the usual suspects we call them. All right, who wants to yell out another one? Upbeat. So upbeat and downbeat are similar, except upbeat, the down phase, slow, is pathologic, corrective upbeat. And again, when you look up, it'll be worse. So that's Alexander's law. Nystagmus tends to be worse in the direction of the fast phase. So it's worse in the direction of the fast phase. And upbeat, U, localizes to vermis, V, because it's a cerebellar central vestibulopathy. So the problem is the connection between the central and the peripheral vestibular system. It can be anywhere in the posterior fossa, including the medulla, the midbrain. So upbeat and downbeat, even though the test says it localizes to these places, you still have to image the posterior fossa because it's a disruption of the neural network connecting the central and the peripheral vestibular pathways at the level of the cerebellum. So upbeat U, vermis V. More. Convergence retraction nystagmus. So convergence retraction nystagmus is not really a nystagmus. So what it is it's a convergence. The eyes are going in, and the retraction, and it looks like a nystagmus. It's worse when they look up because they're trying to generate it. And where does this localize to?
Also.
Dorsal midbrain. Do you see the pattern now? So, the convergence retraction C localizes to the dorsal midbrain D. The upbeat U goes to vermis, the downbeat goes to cervical medullary junction. So it's kind of an easy mnemonic for you to remember these localizing forms. I don't know if the guy's still here to bring in a eraser. Oh, it's here. Okay. So the dorsal midbrain syndrome, the dorsal midbrain contains important structures. Convergence retraction is just one of those. Can you name the other fellow travelers of the dorsal midbrain syndrome? What else lives in the dorsal midbrain? The third nerve. And so with the dorsal midbrain syndrome, what you have is firing of things in third nerve because it's disinhibition. So you're turning off the inhibitor, and so things fire. So the third nerve is medial rectus. So then the eyes will do what? If you turn on the medial rectus, converge. And if you fire both the superior rectus and the inferior rectus at the same time, you'll retraction. So it converges and retracts because you have disinhibition of the third. So things in the third, in both eyes, are going to fire convergence retraction. There's no lateral rectus because which nerve is that? That's sixth. And where does that live? In the midbrain? That lives in the pons. So because the pons is not involved in the dorsal midbrain, the lateral rectus is not involved, convergence, retraction. What else does the third nerve do? What else does the third nerve do? The pupil. And so with dorsal midbrain, we'll have light near dissociation to the pupil. The pupil with poor response to light, but better to near. Light, near retraction. And what else does it do other than the motility and the pupil? What else does the third nerve do? The levator. And so you'll get this lid retraction sign. And the name of that lid retraction sign is the Collier's lid retraction sign. So the combination of lid retraction, the levator is firing, light near dissociation of the pupil, that's the Ettinger-Westphal nucleus in the third nerve subnucleus, and convergence and retraction, nystagmus. These characterize the full dorsal midbrain syndrome. So you need to know what lives in the midbrain, number 3, and that all the eye stuff lives dorsally. Once you start moving ventrically, then your arms and legs don't work. Contralateral hemiparesis, hemisensory loss, all those other things. All right, who knows some more localizing forms in this day? While I'm erasing this. Seesaw. So seesaw looks like a seesaw. You guys don't know what a seesaw is because you've never been outside before, but seesaw, it goes up and down like this. So the eye goes up and down, elevation and depression, and then intorsion and extorsion. So it's going down and up and down and up because it's intorting, extorting, going up and down. And where does seesaw localize to? Paracellar region, but that's a P and that won't match. So we say seesaw up and down with intorsion, extorsion, third ventricle area, T. So the S, seesaw, localizes the T, the third ventricle. And as you know, the lateral ventricles and the third ventricle, the chiasm is the floor of the third ventricle. So this is a coronal view. Lateral ventricle, number 3. This is chiasm, and this is the cella. So the lesion is right here in the paracellar region because it's the floor of the third ventricle. And so what would be the associated finding in a seesaw nystagmus that would localize to the chiasm? What would be the visual field finding? Yeah, so we're going to be looking for the bitemporal hemianopsia. So this one also MRI, but in this case, third ventricle, they all need an MRI. Most of the nystagmuses need MRI, the posterior fossa, but this one, seesaw, S, localizes the third ventricle, paracellar region T. More. Who has more localizing nystagmus? What's that? Periodic alternating nystagmus. So periodic alternating nystagmus can be congenital or acquired. And what it is it's periodic, means it comes one direction, alternates the other direction. So here's what it looks like. I'm beating to the right, and then it slows down, and then it starts beating to the left. And what that means is you must observe every horizontal nystagmus for at least 60 seconds. Because what you're looking for is in that 60 seconds, you're looking for periodicity. It's going to be periodic, and it's going to alternate. This localizes to the cerebellum, but it doesn't localize any better than that. So you need an MRI. So PAN is a cerebellar type of nystagmus as well, but it doesn't tell you exactly what it is. So there's acquired and congenital forms. The reason you need to know this one has a treatment. Who knows what the treatment is? Baclofen. So you need to know that for the test. All the other forms of nystagmus, the treatments suck. But this one, baclofen does work on this one. Baclofen. The same stuff we use for spasticity, we use for this. Baclofen, PAN. So you got to watch it for 60 seconds. And so the apocryphal story from my residency is the resident went in and said it was beating to the right. And then the medical student goes in and sees nothing. And then the fellow goes in and it's beating to the left. So they go present to their attending and they say, what did you guys see? I saw right beating horizontal nystagmus. What did you see, fellow? It was left beating. I don't know what that resident was seeing, but it's going to the left. And then the medical student says, I didn't see anything. The eye looked straight to me. So when you hear that story, no nystagmus, right beating nystagmus, left beating nystagmus, all in the same patient, that is a periodic and alternating nystagmus. And where does it localize to? Cerebellum. And the treatment? That was terrible. You guys got to participate. All right. I can see if you're not saying the words, okay? What's the treatment? What's the treatment? Where's it localized? You need to know that. So, if we're going to spend any time today, I need to hear that you want to be here. And the way that you tell me that you want to be here is by participating. Okay? It's a participatory sport. Neuro-ophthalmology is a team sport. We're in this together. If you can't remember what I tell you, just Google it. I will just go over it again in YouTube. You can literally leave the room and YouTube it in 3 minutes. You'll be as smart as me and go back in there and you'll know exactly what it is. Because I'm going to be there with you. Right? I'm going to be with you. All right. There's a few more localizing ones. Who wants to name them? Got any more localizing ones? So the congenital motor nystagmus, that's a kid thing. It's congenital. We really don't know if it's motor or sensory. So we just call it congenital nystagmus. The way you figure out whether it's motor or sensory is you have to examine them. But when they're a kid, the exam sucks. So every infant with congenital nystagmus, you got to make sure they can see. So can the child see, yes or no? If they can't or you don't know, you're still going to have to MRI this. And you're going to have to do an ERG to see if it's the retina. Because there's some things where the retina looks normal, but it's still the retina. And those things are Leber's congenital amaurosis, and there's just all sorts of things where the retina looks normal in a kid whose eyes are jumping. The type of nystagmus, it doesn't localize. So it can be horizontal jerk, it can have rotary component. It just means there's been a maturation failure here. And you don't know whether the maturation failure in the system is motor or sensory. You have to examine them, make sure they can see, check their pupils, and then you still have to image this. So it's not localizing, but you do need to work it out. All right, more? Okay, gaze evoked nystagmus. Do you think that is localizing or non-localizing? Non-localizing. In fact, everybody in this room probably has a few beats of gaze evoked nystagmus. It's exactly what it sounds like. It's evoked by gaze. So when they look to the right, your neural integrator is supposed to keep your gaze held there, but it gets weak, and so it drifts towards the midline and then corrective saccade back to the gaze to the right. So that is a normal thing because there's elasticity in your orbit, and so it doesn't want to stay all the way over here. But what happens is your neural integrator figures it out, and so in a normal person, a few beats of jerk to the right, and then it just stops. If it persists, it's pathologic. Or if you come off a few degrees from the extreme gaze, it should stop right away. So later at the break, you guys can check each other for gaze evoked nystagmus. A few beats of horizontal jerk nystagmus to the right or to the left is fine. Nothing wrong with you. But if it persists, or it's in primary, or it comes off a few degrees and it's still there, that's all pathologic. but it doesn't localize. The most common cause is medicines. And the most common medicines are any central nervous system things, anti-epileptic drugs, sedatives, psychiatric medicines. You just have to Google it to see if they're on any of these meds. So you literally can just ask the AI, here's the patient's med list. Can any of these cause nystagmus? And the AI will answer way faster than watching a YouTube video of me answering. The AI is going to take over some of these things. Yes? But it's not localizing. The thing you need to know with gaze evoked is it peripheral or is it central? So who knows what defines a peripheral versus central nystagmus? Peripheral versus.
Peripheral would be like ear problems.
Yeah, so the peripheral ones are your ear, ENT. That has nothing to do with us. That is neuro-otology, not neuro-ophthalmology. So how do we differentiate peripheral from central? Well, in the peripheral lesions, they have these canals. They're called the semicircular canals because they're semi and circular. And these semicircular canals talk to the vestibular nerve. And so when you rotate your head, the little rock otolith inside your ear smashes on the hair cells and tells your head you're rotating. This is peripheral. So all sorts of things can go wrong with your peripheral vestibular system. Meniere's disease, labyrinthitis, but the most common acute form is benign and positional and paroxysmal. What's the name of that thing when you have benign and positional paroxysmal vertigo?
It is benign.
Yeah, that's what it is. It's benign positional paroxysmal vertigo. That doesn't come to us, okay? So the question you need to ask about these people is it position of you or position of your head, or it doesn't matter what position you're in. If it doesn't matter what position they're in, that's central. However, when we're looking at the nystagmus, we can tell if it's from your semicircular canals or not. And there are 3 semicircular canals. You would think they would just, ENT would just name them to match, but they don't. There's a horizontal one. That one makes sense because it's horizontal. And then there's a superior one, and then it should be an inferior one, but they changed the name. Yes? So what are the names of these things? Superior, horizontal, and what is it? I wish it was vertical. It's not. Who knows the names of these canals? Lateral. It should be like lateral, medial, horizontal, vertical, superior, inferior. Instead, they picked one of each. So you got a superior, a posterior, and a horizontal. The reason for that is when you rotate your head, we have 3 rotational freedom of movement with our head. Our head cannot move in every direction. It can only move up and down. This is called the pitch plane. Side to side, this is called the yaw plane. And it can tort, which is the roll plane. So when you tilt your head, what happens when you tilt your head? You're not doing it. Okay, when you tilt your head, does the world tilt with you? Yes or no? Nope. In fact, you don't even notice it. When you tilt your head, the world just stays up and down. Is that right? Yes? Okay. And that's because when you tilt your head, your ear tells your eyes to rotate in the opposite direction. So when you tilt your head like this is what really happens. So really what happens every time you tilt your head is this. Tilt head goes like this and then it rotates back. You didn't see any of that. To you, it looks like straight up and down, isn't it? Do it again. Look, prove it to yourself. Yes? You don't notice it, but really, every time you tilt your head, this is what happens. It's like a windshield wiper. That's weird. What that means is you are suppressing all of that activity cortically. So really, what you saw was the whole world went like this, and then the whole world went back like a windshield wiper, like this. Your brain just turned that all off. That's weird, don't you think that's weird? That you have cortical suppression of that movement. So when you have the semicircular canals involved, the horizontal one is going to be unidirectional if it's peripheral vestibular. But if it's central, it'll be right beating in right gaze, and left beating in left gaze, and up beating in up gaze, and down beating in down gaze. So that gaze evoked, if it's bidirectional and horizontal, is central. If it's unilateral, you're going to define the travelers. And what other travelers live with the vestibular cochlear nerve? What do you think? Other than their vestibular nystagmus, what else do they have if their cochlear is out? Hearing loss. So they're going to have hearing loss, dizziness, tinnitus, acute, and it better be unidirectional because what's happening is the vestibular system is weak on one side and then you have a corrective saccade. So that's a problem with the horizontal canal. However, the superior and the posterior or the lateral and whatever names you've decided you're going to use from an ENT standpoint, they have to do double duty. They have to do both the pitch plane and the roll plane. So there is no vertical. I wish there was. I wish there was just a horizontal, a vertical, and a torsion. That would be so much easier, but it's not. The other two semicircular canals are oriented at a slight angle like this. You remember that from anatomy? That the semicircular canals aren't oriented in the pitch plane, the yaw plane, and the roll plane, which means the other two canals have to do double duty. They have to do both the roll plane and the vertical pitch plane. And that means if you have strictly downbeat or upbeat nystagmus, that localizes. That's central. You understand why the purely upbeat and the purely downbeat nystagmus cannot be from your semicircular canal because it cannot do that. There is no vertical canal. There is no V canal. There's only, it does both the roll plane and the pitch plane. And what that means for you is peripheral forms of nystagmus cannot produce purely rotary, upbeat, or downbeat nystagmus. This is the defining feature of central. So, who gets to see the person if it's acute, bidirectional, or purely rotary, or they have nystagmus? Because this thing right here can't cause double vision. So if they have skew and they have diplopia, that's central. If the nystagmus is purely vertical, it's central, upbeat or downbeat. If it's purely rotary, that's central. It's usually the medulla. And if they don't have any hearing loss or tinnitus, that's central. Now, ENT has a bunch of ways they can tell. It's the ear. Who wants to tell me the name of, you take their head and you go like this, and try and get their nystagmus. What's the name of that? That's the Dix-Hallpike maneuver. That's right. So you need to know that ENT saw the person for nystagmus, hearing loss, tinnitus, and they did the Dix-Hallpike and it's positive, and it's a horizontal unidirectional, or it's a combined horizontal vertical torsional. That has nothing to do with us. That is ENT, not I. That is neuro-otology, not neuro-ophthalmology. You're also going to know from ENT's note that they thought it was central because they're going to order an MRI. So they have a bunch of toys, just like we have a bunch of toys. They have rotary chair and VNG and VEMP. You don't need to know any of that. You just need to know that if they saw ENT, they did the Dix-Hallpike, it was negative, and they ordered an MRI, that they think it's you. They think it's neuro. Central. All right, so the questions. If the patient has purely central vertical nystagmus, upbeat, where's that localized to? Irmis. How about downbeat? Cervicomedullary junction. Most common structural cause? PPR malformation. You have to image it with a MRI. And the gaze evoked nystagmus, your main job is making sure it's unidirectional or bidirectional. Which one's the central? Bidirectional. So anybody with bidirectional gaze evoked nystagmus, it is central. That's us. Neuro-op, not them. Neuro-otology, that's us. Most common cause, meds. In the United States, the most common cause is alcohol. But you don't have no alcohol here, so yeah, maybe you don't. So in the United States, if they pull you over for drunk driving, they shine this light in your eye and they say, follow this light. What is the police officer looking for? Gaze evoked bidirectional horizontal nystagmus. Do you understand what they're looking for? That is what they're looking for. So if they shine the light and they see your eyes jumping, they're going to arrest you. Yep, this thing is called the field sobriety test. Maybe you don't have that. If they're taking medicine. So for you as a doctor, what should you be telling all your patients who are on these medicines, these psychotropic medicines, epileptic drugs, sedative? What's that?
Avoid driving.
Yeah, what do you have to tell them? They can't not drive. They just have gaze evoked. They're fine straight ahead. You have to have a note in your car so that they don't get arrested. Okay? So, hey, officer, how much have you had to drink? Are you been drinking? No. I have this note from my doctor. I have gaze of both horizontal nystagmus because I'm on this medicine, Tegretol. Yes, you understand what you're supposed to tell the patients. Otherwise, they might get arrested. And in your country, it's pretty stiff problem. Yeah, you get arrested for that, you might get kicked out of this country. Yes, when you just on Tegretol because your doctor didn't tell you, and then you got kicked out. Wouldn't that be sad if they got kicked out for being a seizure patient on Tegretol? That'd be sad. All right, the last one you need to know about is called rebound. Rebound. And it's like gaze evoked, okay? So it's a gaze evoked to the right, but then when they come back to center, it starts to go to the left. So it's like PAN, it's a periodic alternating, except it's evoked by gaze. So rebound is like a basketball. You hit the backboard and it rebounds back to you. So it goes to the right, back to the center, starts to beat to the left. So it's different than PAN, which is periodic. In rebound, it's gaze evoked and then switches direction. So they're both cerebellar forms of nystagmus. So you should now know the localizing forms of nystagmus. Downbeat localizes to cervicomedullary junction, most common cause. And TR, but you got to order the antibodies, the vitamins, syphilis serology, the usual suspects. Everybody gets the same workup. Okay. Upbeat, vermis, but it can also be medulla, posterior fossa, doesn't matter. MRI, everybody gets the same workup. Convergence retraction C goes to. That's defined by the fellow travelers in the dorsal midbrain. Cohere's lid retraction, Leitner dissociation, convergence retraction, nystagmus, and the skew deviation and Leitner dissociation of the pupils. Rebound and PAN localized to cerebellum. And you should know that you should watch every horizontal nystagmus for at least 60 seconds to make sure it's not PN, because that one's treatable with. Okay, that took 25 minutes. Do you understand everything I've told you about nystagmus? Because every other form of nystagmus, non-localizing. Non-localizing. Most common cause, alcohol. In your country, it's probably your doctor's cause. Yes.
ICA infection can present like peripheral.
What's that?
ICA infection.
ICA?
Anterior cerebellar artery.
Yeah, so anything that disrupts your cerebellum, including anterior or more commonly the pica, the posterior inferior cerebellum, but it doesn't matter what the cause is. If you damage your cerebellum, regardless of whether it's cerebellar artery infarction, demyelinating disease, brain tumor, meds, alcohol, it'll all look the same to you. So you cannot tell what the etiology is by looking at their nystagmus. You can only tell localization. So who knows what the pica infarction's name is? Yeah, lateral medullary syndrome. What's the name of that? The eponym?
Wallenberg.
Wallenberg. So you need to know that Wallenberg is our most frequent cause of rotary nystagmus, but it's accompanied by the fellow travelers. Horner syndrome on the ipsilateral side, a crossed sign, face on one side, body on the other side. So the face and Horners are going to be ipsilateral. The contralateral is going to be the body. That is the lateral medullary syndrome, the Wallenberg syndrome. It's in the medulla, it's pica. But ICA can also cause these nystagmus.
This is what I mean. There's no way to tell unless I do MRI. Right?
There's no way for you, are you guys all ophthalmologists?
Neurologist.
All neurologists. Yeah, there's no way. So ICA is defined by other ICA symptoms, and PICA it's defined by its fellow travelers. But the nystagmus waveform is not going to be able to tell you where it is. The nystagmus alone just tells you cerebellum, that's it. It cannot tell you where in the cerebellum. It's not that precise. Got to do an MRI. However, if the MR is negative, there are just some things we can't see on MR. Vitamins, antibodies, infections. That's why you have to order the usual suspects. All the tests are the same. Anti-GAD antibody, paraneoplastic antibody, B12, folate, your thyroid, check their med list. Everybody gets the same workup because you can't tell. So you cannot tell etiology by looking at their nystagmus. You can only tell location. That's it. All right, switch gears. What else you guys want to know? because we have 2 days. We're going to cover all of neuro. So here we go. The common things. Don't pick weird things. Pupil. Should we do pupil?
Yeah, pupil.
All right. Now you get to make a choice as you fix the slides. We can do the slides, or we can do it like this. Which would you prefer? Like this? I prefer like this too, because most of your teaching is like super boring. It's PowerPoint, and about halfway through the PowerPoint, I would say half of the back of the room is already on devices. That's just the way it is. All right, so anisocoria. Anisocoria. Coria, it means pupil. Iso, it means same. And an, it means not. Anisocoria, not same size pupil. Anisocoria. There's only 2 things that the pupil can be. It can be bigger, and that's it, or smaller. So you have to decide right away, is it the bigger pupil that's the problem, or the smaller pupil that's the problem? So in anisocoria, if it's the bigger one that's the problem, the bigger one can't constrict, or that's the little one that's a problem, little one can't dilate. So there's 2 systems that control our pupil in the autonomic system. What are the names of the 2 systems? Sympathetic and parasympathetic. Which one is the problem if it's the bigger pupil that's the problem? Big. Which nerve controls that? And this smaller pupil is the problem? That's sympathetic nervous system, and that's got a name, the Horner syndrome. So, the first thing you're going to do when you're confronted with anisocoria is you're going to check the pupil in the light and and you're going to check the reaction to the pupil to see if it's the bigger one not constricting, but you also must test if the little one isn't dilating. And so, as a neurologist, there's something I want you to never write ever again. What is the thing I don't want you to write ever again? Who knows what this means? Don't do this ever again. Pupil equal round reactive to light and accommodation. Isn't that what they teach you? Perla? Don't do it. Why? Because the pupil can be equal, round, and reactive to light and accommodation. That is only testing one of these systems. Which system is it testing? PNS. The parasympathetic nervous system. So, it should be duh, right? Duh. Pupil equal, round, reactive to light, and in the dark, and accommodate. And there's no assessment of the relative afferent pupillary defect in Perla. So there are 3 things you're going to be testing with the pupil: the integrity of the parasympathetic, the integrity of the sympathetics, and the presence or absence of a relative afferent pupillary defect. Parasympathetic and sympathetic are efferent, that's motor, and this RAPD is afferent, that's sensory. When you write Perla, you literally wrote, I'm only going to test one of the 3 things I'm supposed to be testing in this person. I'm supposed to be testing anisocoria in the light, that's Perla, but also in the dark. There's no assessment of the dark in Perla. It only is equal, round, and reactive in the light and accommodation. And you didn't test the afferent. You have to swing the flashlight from the right to the left to detect an RAPD. So instead of only doing 1 of 3 Perla, you have to do all 3. So I'm okay if you write Perla as long as you write duh and no RAPD. That's all 3 things. But Perla, you're literally only checking 1 thing. So don't do that. All right, so if the anisocoria is greater in the light and the bigger pupil doesn't constrict, is that sympathetic or parasympathetic? That is parasympathetic. So I got a little pupil and I got a big pupil and I shine the light on this one and it doesn't constrict. Or it constricts a little. That's the parasympathetic. Okay? If you're in the dark, it's the little pupil not dilating. So this one dilates, and this one doesn't dilate. So this is in the dark. So you need to check the pupil in the light and also in the dark. Okay. So if it's worse in the light, that means the big pupil is not constricting. That's third nerve until proven otherwise. However, third nerve is defined by the company it keeps. What are the other two things that have to be present to make it a third nerve palsy? Ptosis and the motility, yes? So if there's no ptosis and no motility deficit, that's extremely unlikely to be a third nerve palsy. What that means is it's likely to be something wrong with the post-ganglionic nerve or the post-ganglionic connection between the nerve and the muscle or the post-ganglionic muscle itself. So whenever we have a neurologic deficit, it can be the nerve, the muscle, or the junction. Nerve, the muscle, or the junction. In order to define something as third nerve, we need to have three pieces. What are the three pieces? Ptosis, pupil, and motility. What if you only have the pupil? Then that's extremely unlikely to be pre-ganglionic third nerve palsy. That's way more likely to be post-ganglionic, either in the ganglion, the post-ganglionic nerve, the junction, or in the muscle. So what would be the most common cause of a muscle problem causing a bigger pupil? What do you think the most common cause is? Something wrong with your iris. Trauma, sphincter rupture. However, that trauma doesn't have to be punched in the eye or car accident. It could be the eye doctors did it. Surgery, eye surgery. So they all have to have a slit lamp exam. All of them. So as a neurologist, you don't have no slit lamp. So if it's just the pupil, you just look at the iris and what you're trying to decide is it regular or not? As soon as it's irregular, that person needs a slit lamp exam. They have to have an eye exam. Pupil is a team sport. There is no I in team, but there is an eye, okay? You have to look in the eye as part of the team. And that means you got to make a friend, phone a friend. That friend is ophthalmology. So the most common cause of an isolated dilated pupil, if it's the iris, is you got punched in the eye. But the second most common cause is something happened in your eye, but not trauma. Uveitis, glaucoma, drops, surgery. Something happened to their eye. That's an eye thing. It has nothing to do with you. And if it's just the pupil, you don't need to scan it. So if it's post-ganglionic, regardless of whether it's antistonic pupil or iris damage or pharmacologically dilated, that doesn't need an MRI. No, there's no MRI police here in Kuwait to come get you, right? So if you scan an isolated, dilated, bigger pupil, nobody will come. But it's kind of a waste of money. Also, you scared the patient because you told them it might be a third nerve palsy. All right, what are we worried about with the big pupil third nerve palsy? What are you worried about? Big pupil, big ptosis, big motility deficit, XT, aneurysm. And where's the aneurysm? Posterior communicating artery. And therefore, the imaging study of choice for third nerve palsy with the pupil is CT, CTA in the emergency room, followed by MRI, MRA, because the MR is better for non-aneurysmal causes of third nerve palsy. So it's not CT versus MRI. You have to have both. We need a non-contrast CT in the emergency room for what? What are you looking for with the non-con CT and the people involved third? Aneurysm. But what are you looking for first before you find? When you have a pupil involved third and they got a headache, why are we doing a non-contrast CT for subarachnoid hemorrhage? So if we see subarachnoid hemorrhage, you're done. That needs to go to neurosurgery. So CT, non-contrast first. What are you looking for? The subarachnoid hemorrhage. If you see that, of course, it's the aneurysm until proven otherwise. Then CTA, that requires the contrast material. Looking for the aneurysm. And where's the aneurysm? PCOM, but it doesn't have to be PCOM. It can be ICA, it can be basilar. You don't know. Just make sure it's not an aneurysm. And that kills people. So you need to not let the sun set. This morning, I heard that if you're in the public hospital, you might have a 3-month wait for your imaging. This one, you cannot let the sun set on people involved third. People involved third is aneurysm until proven otherwise. If it ruptures, half the people just die at the scene. if they survive the rupture, half of those people are going to be permanently neurologically impaired. But what if you make the diagnosis before the rupture? Clip, coil, go hospital, day 3, home. That's a save. So do not let the sun set on this bigger pupil. Big pupil, big ptosis, big motility, big problem. That's aneurysm and too proven otherwise. Non-contrast CT for subarachnoid hemorrhage first, followed by contrast CTA to look for that aneurysm, and you still need an MRI after that. Why? Because there are things you can't see on a CT CTA, like cavernous sinus, meningioma, or 10 million things that a CT sucks for. So it's not either or, it's both. CT CTA followed by MRI, and we add the MRA on there. So you understand about third now. However, if there's no ptosis and no motility deficit, then the thing you're worried about there is postganglionic or ganglionic. Okay, the ganglion. What's the name of the ganglion for the pupil? Ciliary ganglion. All right, so the ciliary ganglion, if the ciliary ganglion is damaged and there's no cause, what is the name of that problem? Who wants to tell me what the name of that is? So it's a dilated pupil. It doesn't react to light. 80s tonic pupil. All right, so you need to know that one, okay? 80s tonic. So what happens with the 80s tonic pupil is you got a small pupil and a big pupil. Does this pupil react to light in 80s? Yes or no? It's parasympathetic nervous system damage. The pupil is bigger, but it's damage to the ganglion. So the light reaction will be worse because its parasympathetic is damaged. Anisocoria is going to be greater in the light or the dark? In the light, because the light. So if the light is poor, the light reaction makes the anisocoria worse because this normal pupil will constrict. So the light will make this normal guy constrict. This guy not constrict as much or doesn't constrict at all. So the ganglion is called the ciliary ganglion, and the ciliary ganglion provides innervation to the iris. So this ganglion is cranial nerve 3 to the ganglion to the iris. So when you have damage to the ganglion or the pes ganglionic nerve, just like damage to any peripheral nerve, what will happen over time after the nerve is denervated? What's the normal thing that happens to a nerve that's cut? It'll regenerate. There are two ways that it can regenerate. Normal regeneration or aberrant regeneration. Aberrant means it went to the wrong place. So both are regenerating, but one is normal and one is abnormal. The abnormal one is called aberrant. Okay, so in a normal person, there are 30 times more fibers going right here to the ciliary body to do accommodation. Because that muscle, the ciliary body, makes your lens change shape so you can read something at near, is 30 times larger than the iris. And so under normal conditions, most of the fibers go to your ciliary body for accommodation of your lens, not your pupil. But when you have denervation, you damage the ganglion or the postganglionic nerve, what happens is the nerve regrows. And some of the fibers that used to go to the ciliary body now go to your iris. So when you look at something at near, your brain thinks you're accommodating, but what is actually happening to the pupil? Is it dilating or constricting? Pick, dilate or constrict. It's constricting. And that means the light reaction is poor, but the near reaction is better after denervation to the ganglion, and that light-near dissociation is what we see in atonic pupil. The light reaction is poor, the anisocoria is greater in the light. You shine the light on the big pupil, it doesn't constrict as much, but then you ask it to do near, and because of aberrant regeneration, the fibers that used to go to the ciliary body now go to the iris, it constricts. And the second thing that happens after denervation in a peripheral nerve, at the postsynaptic receptor, what happens to those receptors in response to denervation? Upregulation. So there's much, much more receptors now because when you denervate a nerve, it says, hey man, where's the signal? I can't hear you. Can you hear me now? I can't hear you. Can you hear me now? So there's going to be upregulation of the postsynaptic receptor. And so we can put a drop up here. What's the name of the drop to activate the parasympathetic nervous system? Pilocarpine, which is a direct acting parasympathomimetic. So it's going to directly activate the parasympathetics. And how much pilo are we going to put in there if you're looking for denervation? Full strength or dilute? Dilute. So in normal person, 1/10% pilocarpine, which is very dilute, does nothing. So it does nothing to a normal pupil. But if you put it in antistonic pupil, because of denervation, supersensitivity, upregulation of the postsynaptic receptors, if you put topical 1/10% pilo into this antistonic pupil, what will happen to it? Will it dilate or constrict? Constrict, because you're making the parasympathetic fire. So even though the nerve is damaged and the ganglion is damaged, we can still activate the muscle because we're bypassing the neuromuscular junction, just putting drop directly on the iris, and it'll constrict. So the very first thing you have to do in antistonic pupil is make sure it's not the bad thing. What's the bad thing for big pupil? Third nerve. That's your job. Make sure it's not third nerve palsy. No ptosis, no motility deficit. Then you're trying to confirm that it is antistonic pupil. You're going to look for light near dissociation. The light reaction is poor, the near reaction is better. What causes that? Aberrant regeneration. And you're going to put 1/10% pilocarpine in there. It will make it constrict. This will confirm that it's antistonic pupil. You're done. No MRI needed. It's benign. There's no treatment. There's nothing's going to happen to them. It's just benign. If it's bilateral, you should order the syphilis serology. If it's bilateral, you have to scan them. Because that light near dissociation can also occur. And you heard of where this was before. Where is that other place the light near could occur? Dorsal midbrain. So it's bilateral light near dissociation, scan it. If it's unilateral, you don't have to scan it. If it's antistonic pupil, that's idiopathic. You don't have to scan it. Your main job, make sure it's not third nerve palsy. The competing hypothesis for this pupil to be bigger with no light reaction is that it's pharmacologically blocked. So they put something in there, atropine or something, or scopolamine. That's our most common in the U.S., scopolamine, because we use that for going on a cruise. You put it behind their ear to prevent motion sickness. And they forget about it, they touch their hand, touch their eye, get dilated. But we also use it after surgery. You guys use this scopolamine after surgery here?
No.
So they put it behind their ear to reduce post-op nausea. So scopolamines are #1 in the USA for pharmacologic dilation. But it can be atropine or cyclogel, it can be anything. So what pilo would we put in there to show that it's pharmacologically blocked and that the receptors are all blocked? What pilo would you put there?
1%.
1%. So if you put 1% pilocarpine on a pupil that is atropinized and is pharmacologically blocked, it won't constrict because all the receptors are blocked. So in order to differentiate antistonic pupil from a pharmacologically dilated pupil, we use pilocarpine 1%. But if you're going to do the pilo, you have to do it in order. 1/10 first, and then 1% second. What will happen if you put 1% into antistonic pupil? It'll constrict, and then you'll think that's a third nerve palsy, when it's not. That's antistonic pupil. So 1/10 first, then 1%. So why would you get this mistaken? Because in the acute phase, there's no time for the aberrant regeneration to occur. So in acute antistonic pupil, the light reaction will be poor, but the near reaction is also poor. Why? There hasn't been enough time to develop the aberrant regeneration, and so you have to put the 1/10 first and then the 1% second. What will happen if you mistakenly diagnose antistonic pupil in a pharmacologic dilation patient? What will happen to them? Nothing. But miraculously, their antistonic pupil, what will happen after the pharmacologic dilation wears off? It'll go away, and then you'll say, whoa, your Addies, it went away. And that doesn't happen, okay? So nothing bad will happen to you if you mistake pharmacologic dilation and antistonic pupil. Nothing bad will happen. The one you need to make sure it's not is which one?
Third nerve.
That's your whole job. Third nerve palsy. So when we have a dilated pupil, it could be the nerve, it could be the muscle, it could be the connection between the nerve and the muscle. If it's the nerve, what nerve are you worried about? Third nerve. Big pupil, big ptosis, big motility, big problem. CT, CTA, MRI, MRI. It could still be the nerve post-ganglionic. What's the name of that if it's the ganglion and denervation atrophy and supersensitivity and 1/10 percentile? What's the name of that? That's benign. Addie's tongue. If it's the muscle, that's the iris. That needs team play. That needs ophthalmology. Make sure it's not angle closure, glaucoma, uveitis, surgery, trauma, sphincter tear. You don't have slit lamp, so you have to let ophthalmology see that first. And if it's blocked at the junction, we can test that pharmacologic blockade with a drop, pilocarpine, but you have to put 1/10 first, make sure it's not an acute Addis, and then 1%. What will happen to the pharmacologically blocked people from atropine? Nothing. But no one's going to fault you if you do an MRI on this. If you do an MRI on this, it's going to be normal. It's a waste of money. But, yeah. So no one's going to come. Do you understand the big pupil? All right, the small pupil now. What's the name of the small pupil anisocoria? Horner syndrome. Who wants to tell me the whole Horner's pathway? Yeah, the pathway though. Do you know the pathway? Where does it start? Hypothalamus. Then where does it go? Yep, all the way down to the ciliospinal center of Budge. What level of the spine is it? C8 to T2. So it starts here in hypothalamus, descends posterior lateral brainstem, goes all the way down to C8T2, exits white rami over this huge organ in your chest called your lung. What's the name of the tumor when it's right there? Van Gogh's tumor, you need to know that. Goes up the sympathetic chain onto the internal carotid artery. The chain has an inferior cervical ganglia, a middle cervical ganglia, and its synapse is at the superior cervical ganglia. Superior, the top. Passes up these ganglia, synapse, onto carotid, into cavernous sinus, short course on 6, then 5, division 1 to the eye. So it goes all the way down like this. Hypothalamus, posterior lateral brainstem, C8T2 in the chest, white rami, over apex of lung, up the sympathetic chain, superior cervical ganglia, carotid, cavernous sinus, back to the eye. Shouldn't it just go like this? But it doesn't. It goes all the way like this. And that means if you only do an MRI of the head on the Horner syndrome, you'll miss the things that kill people. There are 2 things that kill people. In the acute setting, something could tear this artery. What's the name of this thing? The carotid dissection. So acute, painful, Horner syndrome, carotid dissection until proven otherwise. And then chronic, Pancoast tumor. So the 2 things that kill people are south of this line. So as a neurologist, you need to have a Horner protocol. So I care about what you write in your evaluation. Make it good, because I just love visiting. But I care more about you and your patients. I want you to write down that you did this scan and you found something because you came today. That you saved something. The most common error for a neurologist missing a life-threatening cause of anisocoria is failure to order the angiogram in which one? The big people or the small people? Was it the big one or the small people one that's the aneurysm? The big one. So in third nerve palsy, you need an A to find that A. What A are we looking for? Aneurysm. What A do we use to find aneurysm? Angiogram. There is no A in MRI. You must have some kind of A with third nerve palsy. CT, CTA, followed by MRI, MRA. You need an A. There's no A in MRI. So the most common reason a neurologist would miss a pupil-involved third nerve palsy aneurysm is they didn't order an angiogram. They did an MRI of the head. You understand how important that A is. You need that A to find that A. There is no A in MRI. However, if it's the small pupil, what's the name of that syndrome? That's the Horner syndrome. If you order MRI of head, the reason you didn't find the dissection or the pancreas tumor is you imaged the wrong area. The MRI has to go all the way down. How far down does it have to go? Thoracic T2 in the chest. And that means the behavior change. You have to have a Horner protocol. So wherever you're working, you need to have two protocols. One is aneurysm protocol for third nerve. That's the big pupil, big ptosis, big motility. Big problem. But how about small ptosis, small pupil? Also big problem. Also, it doesn't matter what the size of the pupil is and what the size of the ptosis is. Big pupil, big ptosis. What's that one? Third nerve palsy. Little pupil, little ptosis. What's that one? That's also a big problem. How about big ptosis, little pupil? That's cavernous sinus. That's also third nerve palsy. How about little ptosis, big pupil? Also third nerve palsy. So 3 of the 4 combinations of pupil and lid are third nerve palsy. It doesn't matter whether it's big and big, big and little, little and little, little and big. They're all bad. All of them are bad. Do you understand what I've said? It's your job to identify droopy eyelid plus abnormal pupil. That's your job. Do your job. You signed up for this job, yes? You love this job. We'll prove it. All right, if it's the small pupil and the small ptosis, what's the name of that syndrome? Horner syndrome in the acute setting, CT, CTA, head and neck, all the way down to thoracic T2. What are you looking for in the acute setting? Carotid dissection. And just like the aneurysm, if you don't diagnose the dissection, they're going to stroke because it's going to thromboembolize. And they need that fantastic treatment, aspirin. Yes? So admit to the hospital. Admit to the hospital. All right. So the Horner syndrome is the sympathetic nervous system. The third is the parasympathetic nervous system. They're both bad. For the Horner syndrome, we're going to put a drop in the eye because the anisocoria is going to be greater in the light or the dark? In the dark, because the pupil doesn't want to dilate. Because it's a sympathetic problem. So anisocoria greater in the dark. That's the sympathetic. That's the Horners. And if we want to test the integrity of the sympathetic pathway, we have to give a sympathomimetic, something to activate the sympathetics. Now you can, in the book, and you got to learn these book ones, cocaine, which stimulates, which inhibits the reuptake of norepinephrine at the junction, and hydroxyamphetamine, which stimulates the release. But here in Kuwait, good luck getting any cocaine here. Yes? Houston, Texas, I can get cocaine outside my hospital anytime. But not here. Yes? Probably banned in Kuwait. Yes? So same with amphetamines. So the drug you have is aproclonidine. Aproclonidine. You have this drop? Yes or no? You have aproclonidine? So it's a glaucoma drop, okay? So you need to make a friend with ophthalmology because they have it. Okay? You gotta go talk to your friends in ophthalmology. They have this drop, aproclonidine. Okay, aproclonidine is a sympathomimetic. However, there are 2 types of sympathetic receptors on the pupil. Alpha number 1 and alpha number 2. They act opposite. One is presynaptic and one is postsynaptic. The postsynaptic is alpha 1 or alpha 2? Alpha 1. The alpha 2 is presynaptic. So alpha 1 and alpha 2, they're antagonistic. The alpha 2 tells your junction you're done. You stop doing it. Yes? It's a feedback loop, a negative feedback on the alpha 1. Aproclonidine and its cousin clonidine are alpha 2 predominant, which means weirdly that even though they're sympathomimetic, they do the opposite of what you think they do. So clonidine is used for what? Treat what disease? No, clonidine. No, And what's clonidine used for?
So that's
It's for hypertension. Normally, if you give a sympathetic, you'll make your blood pressure go up. But clonidine is an alpha 2 predominant central acting drug. So clonidine lowers your blood pressure because it is alpha 2 predominant, not alpha 1. Apraclonidine is also alpha 2 predominant. But remember, when you have denervation, what happens after denervation? Upregulation of the postsynaptic receptors. Which one's the postsynaptic, alpha 1 or alpha 2? Alpha 1. So after denervation, the alpha 1 effect will predominate, and that means if you put apraclonidine into this Horner syndrome right here, it'll dilate this little pupil. And so it'll reverse the anisocoria. So a pupil that has been sympathetically denervated doesn't dilate properly. And if you wait, it'll lag in its dilation. That's called the dilation lag. So the amount of anisocoria at 5 seconds is less at 10 seconds because it's lagging in its dilation. It's a sympathetic problem. And if you put in apraclonidine into a normal pupil, it'll constrict that pupil because it's alpha 2. Or it'll do nothing. Usually it does nothing. However, if you put it into denervated, sympathetically denervated, because there's upregulation of the postsynaptic receptor. What's the name of that receptor? Alpha 1 or alpha 2? Alpha 1. The alpha 1 will now predominate. It'll reverse the anisocoria. It'll prove this is a Horner syndrome. What if you say what you guys said? We don't have a friend in ophthalmology. We don't have apraclonidine. Just scan them. So if you think it's a Horner syndrome in the acute setting, just scan them. And how far are we going to scan them? From hypothalamus all the way down to where? T2 in the chest. So that's CT, CTA, head and neck, all the way down to thoracic T2. Yes? You got all that?
yes.
You still need to do an MRI because CT, CTA is not as good as MRI. But CT, CTA is faster for dissection in the emergency room. So in the ER, CT, CTA, what are you looking for? Carotid dissection. What are you looking for in the head? Subarachnoid hemorrhage. Same as the cerebral palsy, except different mechanism. Dissection. We don't want that dissection to go upstairs. So, Horner syndrome, is it greater in the dark or the light?
Dark.
It's greater in the dark because the pupil doesn't dilate or doesn't constrict. It doesn't dilate. It'll have a lag in its dilation called a dilation lag. There's going to be big ptosis or little ptosis? Little ptosis because that's the sympathetically innervated muscle called the Mueller's muscle. Sympathetics. Little ptosis, little pupil, big problem. That is the Horner syndrome. And you can confirm it with topical, which will reverse the anisocoria because of its differential alpha 1 and alpha 2 effect. So both the Addis tonic pupil and the Horner syndrome rely upon denervation supersensitivity for their testing to be working topically. For the test, you need to know every single thing I just said. And for the test, even though you can't get no cocaine here, you need to know about cocaine. And you need to know about alcohol for the test, even though you don't have no cocaine or no alcohol, because your test comes from countries that do have cocaine. Your test comes from Canada, yeah? You've been to Canada? There's a lot of cocaine and alcohol in Canada. So, you need to know about anisocoria, greater in the light, greater in the dark. The Horner syndrome. The reason to test with the apraclonidine is the competing hypothesis for anisocoria greater in the dark and the light is physiologic. What percentage of people have physiologic anisocoria? 20%. That means in every single row here, 2 people have it. What if you can't figure out who it is? It's you. So with the break, go check each other's pupil and see who in your row has the physiologic anisocoria. If you have it, you have to tell people you have it. Why? One day you're going to get a headache. And then what will happen? You're going to have a CT, CTA of your head and neck, an MRI, and you have physiologic anisocoria that was there before. Yes? It was there before. So, think about 20%. Think about all the patients you've already examined. How many times did you write down the physiologic anisocoria? That'd be 0. You never wrote it down. You let somebody leave. 1 in 5 individuals has physiologic anisocoria. 1 in 5. I have it. Yes? So go find out if you have it, and also pay attention to people's pupil, because one day they are going to have a headache. Don't you want to write down? So the Perla thing. Don't do it. 20% of people are not Perla. They just have physiologic anesthesia. Think about all the Perlas you've ever written in your life, and how many times you missed physiologic anesthesia because you just never knew. You never knew. You find it sad. So don't do that. All right, tonight I'm going out to dinner. Yeah? When you go out to dinner, what's the lighting? Why is it dim?
So pupils
Why do they want your pupil to dilate?
more emotion.
What's that?
It's seducing effect.
Why is it a seducing effect? Now, which system is activating when your pupil dilates? Sympathetics. What if your culture is you only get to see one thing? Yes? Don't you think you should be able to look across the table in the eyes of the person that you think you love and tell whether they love you? How are you going to tell whether they love you or not? You're going to take them to some place where the lighting is dim or bright.
Right.
Right.
Pick dim or bright. Which do you want to see? Sympathetic or parasympathetic?
Right.
You want to see the sympathetics in that person, don't you? You're trying to gauge whether their heart is doing this, whether their palms are super sweaty, whether they feel in their stomach sympathetic activity, which you call love, but I call sympathetic aggression. All right, so in the restaurant, it's going to be dim. People better dilate. What if it's constricted? They are not into you. You understand what the goal is. Ladies of old used to put in drops in their eye. What was the name of that drop they put in their eye? Belladonna alkaloid. What does belladonna mean?
Beautiful girl.
Type of flower.
It is a type of flower, but what does this bella mean?
Beautiful.
Beautiful. What does this mean? Donna.
Yeah.
Lady.
Beautiful lady. Yes, why would ladies put belladonna alkaloid in their eye? To dilate their pupil. Why are they trying to dilate their pupil? To pretend they love someone that they don't love. Do you understand? The belladonna alkaloid is a plant. Do you have this belladonna alkaloid in your country? You don't have it. So, the belladonna alkaloid in our country is very common. So, people get it in their environment. It's a very beautiful flower. But if you get it in your eye, your pupil will die. So, if their pupil is constricted, that is parasympathetics firing. That is rest and digest. They're just there for the meal. Do you have any questions about anisocoria and the things you have to be worried about with the pupil? Big pupil, big problem. Yes? You need to know you have to change your imaging paradigm because probably MRI is what you just would have answered before. If you answer MRI in the test, it's a fail. You have to say MRI of what? MRI from hypothalamus down the T2 in the chest for the Horner syndrome, MRI, MRA, CT, CTA. So both the Horners and the third have the exact same imaging sequence. CT, CTA, it's just go south of this line. Yes. The CT non-contrast first, but in the same sitting, you have to give the contrast because the CTA requires the dye. For MRI, it doesn't require the dye. So you can give, we give it because you want to look for tumors. The CT non-con followed by contrast CTA head and neck for Horners, just head for third nerve palsy. All the other causes are benign. Addies, pharmacologically dilated, iris damage, physiologic, all benign. The only two things that kill you, Horner syndrome and third nerve palsy. All right, why would a good neurologist make a mistake and only scan their head with the Horners? Because they say their pain is here, in their head, or in their eye. Why? Of course, if they say my pain is in my neck, it's so obvious that's the carotid dissection. Well, I have a painful horners and my pain is in my neck, carotid dissection. I have a painful horners and it's radiating down my arm, brachial plexus, that's a Pancoast tumor. But what if it's headache or eye pain? You're going to think B1, headache, plus Horner syndrome. Where do you think that is? In their head. Isn't that what you think? All right. Why would someone have a dissection in their neck, but they feel it in their eye? Referred pain. What is referred pain? Yes, so the sensory nerve here is V1. They feel the pain in their eye or in their head or around their eye. They say painful here. I have a headache. But their problem is a tear here in the carotid. So which nerve is actually supplying the afferent in the carotid dissection? Who's feeling that pain? I know, but the tear is here. The trigeminal isn't here. Yeah, who's producing this pain? Which cranial nerve? Not 5. 10. So your vagus is supplying your carotid. Now, why does your carotid need to have afferent? For blood pressure. So that is a general visceral afferent. It's visceral, which means it's inside of you, a hollow organ inside of you. So all your hollow organs, stomach, your heart, your blood vessels, your gut, your bladder, have to have afferent. You have sensory input. You need to know when you have to pee. You have to know when you ate too much. You have to know when you drank too much. You need to know stop drinking or stop eating. You're full. Yes? I need to go to the bathroom. Yes, these are general visceral afferents from inside of you. You with me on this? However, the general visceral afferent is terrible about localizing the pain. It's just there to tell you go to the bathroom or stop eating. It doesn't say exactly where the problem is. So when you have the carotid body, it's supposed to be telling you to raise or lower your blood pressure. Or yes, the carotid body, that's the general visceral afferent's job in the carotid. Hey man, you stood up too quick. Send more blood pressure. Yes? However, that cranial nerve 10 meets the nucleus of 5. Where does it meet it? Where do 10 and 5 meet? Because 5 is way higher in the pond. So what does the nucleus of 5 look like? The nucleus of cranial nerve 5. It's a very long nucleus, so it goes all the way up into the mesencephalon, so that it has a mesencephalic nucleus of 5. It's got a pontine nucleus. It's got a spinal nucleus of 5. You've heard of these things, yes? So the nucleus of number 5 is both rostral and caudal. And that means the 10 is meeting at the medulla. The 5 is meeting the 10. And therefore the signal from the 10 might be misinterpreted as coming from your eye. So patients with carotid dissections, they often say their head hurts. But there's nothing wrong with their head. The dissection is in their neck. Most of the dissections are cervical. You with me on this whole referred pain thing? Okay. If you're having a myocardial infarction, your heart feels it. What nerve is feeling it? No, but what nerve is producing this pain in your chest? The vagus. However, the vagus meets in the sensory root ganglion from the same cervical root of your arm. Which arm? Right or left? Has to be the left. So, crushing substernal chest pain radiating down my left arm. Is there anything wrong with your arm? Nope. What if you scan their arm? Do you miss the heart? Yes? That is a referred pain. The general visceral afferent 10, vagus, is mislocalizing the pain to your thalamus and telling you you have arm pain when there's not a damn thing wrong with your arm. Yes? If you have appendicitis, that is general visceral afferent, yes? You might not be able to say where the pain is. You might say I have back pain. Yes? You might say, I have chest pain. I feel it. Where's your pain? Even though we know exactly where the problem is. You have appendix rupture. Yes? If you have kidney stone, they're terrible about localizing where their pain is. Where's your pain? Oh, my back, my spine, everywhere. Kidney stone. But we know that's exactly in the ureter. The ureter is what's feeling that pain. Yes? But he don't know to tell you. He just says it's somewhere in there. You understand about this referred pain and how dangerous this thing is. So when you have pain as a neurologist, when they say their pain is in V1, you're going to think V1 Horner syndrome, cavernous sinus, and you're going to image the head on. Don't do that. Imaging study for the Horner syndrome, CT, CTA, head and neck, all the way down to C2, T2 in the chest. Every patient. Yes? You got this referred pain thing down? Super dangerous, that referred pain. And that means the lesion could be in their lung too. Patients who have the pancreas tumor, they also say their pain is in their eye, even though their lesion is in the chest. That is the general visceral afferent going to the lung apex. That is completely counterintuitive and opposite of every single thing you've been taught about eye pain, probably. V1, that's what you have been taught, yes? They say their pain is there, we say this, but you have to account for referred pain. Do you understand what I've told you about this referred pain? It's super dangerous to not know about referred pain. Otherwise, you're imaging the arm on the left of myocardial infarction. Nothing wrong with that. All right, you got this whole anisocoria thing down? Next, what do you guys want to feel? I have a list what I've got it covered, so it doesn't matter. Optic nerve, okay. So, optic nerve edema, optic disc edema. The very first thing you got to do as a neurologist is, please don't use this word right here for every form of optic disc edema. Papilledema means to us in neuro-ophthalmology, what does it mean? Increased intracranial pressure. So, do not use this word lightly. If you think it's papilledema, what you really wrote was, this person's optic disc edema is from increased intracranial pressure. So we reserve this word, papilledema, for increased ICP. All the other forms of disc edema, we just call it optic disc edema. And that's because the optic nerve has only two pathologic responses to disease. It can swell, or it can be pale. That's it. So the good news about the optic nerve, it only has two responses to disease. Swell, or be pale. The bad news about the optic nerve, it has only two pathologic responses to disease. It can swell, or be pale, which means your buddies in ophthalmology will not be able to help you. All they can say is they saw a swollen nerve. That's it. They can't tell you why. It's your job to figure out why. Yes? Your job. Ophthalmology can tell you that it's swollen. They have no idea what's wrong with this person. And the bad part about it is they might say in their note that it's papilledema, and they don't know that.
Actually, they always consult us all out of edema.
Yeah.
Always.
They're fair.
That's because ophthalmology is scared of any kind of optic disc edema. It doesn't matter what the cause is.
No, it's the other way. No,
Yeah, you're going to be scared of it too. Nobody wants to see it. You're scared of it because you can't see. They're scared of it because they can't see. I know. So you got to work together on this. So if it's bilateral, your first job is to make sure it's not this. But there's no way for you to know that. The only way to know what the pressure is to measure. That is the only way to know, for sure. However, there are symptoms. Remember, there's an order of operation. Symptom, sign, then scan. Okay? In this order. And then spinal tap. Yep. This is the only way to know what the pressure is. Spinal tap. But you got to go in order, okay? So what are the symptoms of increased intracranial pressure? Headache, nausea, vomiting, tinnitus, pulse synchronous tinnitus,
diplopia.
sixth nerve palsy, non-localizing cause of diplopia. And the sign, bilateral disc edema. Then you're going to do a scan. What are the radiographic findings of increased intracranial pressure? Flattening of the globe, empty cella, fluid in the sheath, and you have to have a V to find a V. What V are we looking for in papilledema? What are you looking for with this V?
Venous thrombosis.
Venous thrombosis. So you need a V to find that V. The most common error in imaging papilledema is failure to order the venogram. However, because it doesn't have to be papilledema, you have to do the head and the orbit in disc edema patients. The reason is you're looking for enhancement of the nerve. Enhancement of the nerve or the sheath. The optic nerve has an intracranial portion, an intercanalicular portion, an intraorbital portion, and an intraocular portion. The ophthalmologist is going to look in the eye and see the intraocular portion. Your scan has to do the rest. What if you only do the head? You didn't image the right area. So I told you the most common error for a neurologist imaging the Horners was not imaging the whole pathway. It's the same problem here. You have to image the intracranial and the intraorbital portion of the optic nerve in anybody who has optic disc edema. Because papilledema doesn't cause enhancement of the nerve or enhancement of the sheath, that's optic neuritis. So you cannot tell if it's papilledema by looking at the eye nerve swelling. It's swollen, that's it. That could be optic neuritis, that could be increased intracranial pressure, that could be ischemic optic neuropathy. You have no idea what that is. Ischemia, infection, inflammation, and pressure all cause the disc to swell. You cannot tell what it is by looking at it. It's just swollen, that's it. But we're going to be looking for the radiographic findings of increased intracranial pressure. And it doesn't have to be venous sinus thrombosis. It could just be venous sinus stenosis. And then, if the scan shows the radiographic findings of increased intracranial pressure, the symptoms and the signs are only from increased intracranial pressure, and you do a spinal tap and it only shows increased intracranial pressure, normal CSF, what's the diagnosis? Papilledema, what's the cause? If everything's negative except that's II. In Kuwait, you guys are facing this IIH. Just like you're going to have diabetes going rampant here. Your rate of obesity has increased exponentially with your economy. Your economy and the switch to processed foods and no exercise and too much texting. Yes? What's the rate of your guys' obesity in this country now? 30%? 40%. There aren't enough neuro-ophthalmologists in your country. That means you are going to have to be neuro-ophthalmology. You are going to be facing a diabetic epidemic, an IIH epidemic, a hypertensive retinopathy epidemic, sleep apnea. Look at the size of your sleep center. Yes? It's coming. Yes? IIH is coming to Kuwait. It's here already. You just don't know how bad it is. And then kids, you look on my flight, yeah? You're going to have pediatric pseudotumor here. It's coming. Probably already. Yes?
I saw one case 2 weeks ago.
You're probably going to see one a month coming soon. Yes? We know because we know what this looks like in the United States. I would say half my clinic is IA. Half. Half of my clinic is IA. All right. So, if the nerve is enhancing or the sheath is enhancing, that's not papilledema. If they have any symptom that's not increased intracranial pressure, that's not papilledema. If they have any sign. So in order to make this diagnosis of IIH and papilledema, symptom only of increased ICP, signs only of increased ICP, scan can only show radiographic findings of increased ICP, and lumbar puncture can only show increased ICP, normal CSF. Then and only then can you make the diagnosis of idiopathic anything. And our treatment, what's the treatment? Weight loss plus acetylzolamide diamide. 500 milligrams twice a day is our starting dose. If, however, it's acute and severe, what's the name of this? When it's acute, plus severe IIH. What's it? Fulminant. Yeah, that's the word you need to know. Fulminant. Fulminant IIH. It's defined as acute, which means less than a few weeks, and severe, which means they have loss of acuity centrally, or their field is terrible. And that means you need to have a partner here. Ophthalmology has to be on this case. You need to have a fundus examination, an OCT, optical coherence tomography, and you have to have a visual field on every IIH patient that you see as a neurologist. You don't have no visual field. You don't have no OCT. It's team effort, okay? Team effort. And if it's acute and severe fulminant, and fulminant needs the knife, some kind of knife. They're all S surgeries. Shunt, CSF diversion procedure, sheath fenestration. You have sheath fenestration?
Yes.
And stenting. You have stenting? Stenting, venous sinus stent, and bariatric surgery. But bariatric surgery is stomach surgery, it takes too long. So shunt, sheath, stent, stomach. Those are your choices.
And GLP-1.
What's that?
And GLP-1.
And GLP-1 is going to change the face of IIH. Its treatment mechanism in IIH is both weight loss and direct acting on CSF. So GLP-1 is going to change everything, I think, for your country and for mine, for obesity. The problem is getting it. You have problems getting it here?
No.
You're so lucky. You're so lucky. All right. How about if it's venous sinus thrombosis? Admit. Okay. So thrombosis, admit. Stenosis, don't admit. Thrombosis, anticoagulation, hypercoagulable state workup. Most common cause in our country, birth control. All right. So
doctor, what
yeah.
if we were according to CTV versus MRV?
So a CTV plus an MRI is probably just fine. The problem is that's a weird combination.
No, it's only CT and CTV.
That's not enough. You have to do an MRI. So it's just like the aneurysm. MRI is better for the soft tissue things. So you have to do, if you're choosing CT, CTA, you still have to do MRI, MRA for both third nerve palsy, Warner syndrome, and the combination of CT, CTV alone is not good enough for papilloedema. However, MRI plus MRVenogram is probably good enough. But you have to do head and organ. Head and organ. Because the optic nerve has head and organ. The new book. All right, so what if the symptom isn't compatible with papilloedema? The sign isn't compatible with papilloedema. The scan isn't compatible with papilloedema. And the spinal tap doesn't show elevated opening pressure. Well, then don't call it papilloedema. Well, that word pseudo, it means something totally different. And so we just call that optic dyskinema. Because pseudo-papilloedema means it's not swollen at all. It's disc bruising or it just looks funny. So that pseudo-papilloedema, don't use that word if it's real edema. Just use optic dyskinema. So you cannot tell if this is increased ICP without symptom, sign, scan, and spinal. So really, don't make the diagnosis of papilloedema or IIH until you've done everything. And because the population incidence of obesity is so high in your country, some obese people have a brain tumor. Yes, being obese does not protect you from brain tumor. They get a brain tumor. They can have thrombosis. In fact, they're more likely to have thrombosis. All right, you understand about how to deal with this? Okay, so let's just go through it then. The very first thing you're going to do if you see optic disc edema is make sure it's true disc edema. True disc edema. The only person that can do that is probably your buddies in ophthalmology. So either it's true or it's not. If it's not true disc edema, that thing we call pseudo-papilloedema. Most common cause, optic disc drusen, these little rocks in your eye nerve. You cannot be diagnosing this as a neurologist. You just can't. We have machines, OCT, fluorescein angiogram, ultrasound. The machines diagnose things now, not the doctor. The machines are way better for pseudo-papilloedema. So once they've decided it's true disc edema, it's coming your way, right? Because they're going to get scared of it and they're going to send it. So if it's true disc edema, is it one eye? Is it two eye? As soon as it's two eye, it doesn't matter. Their workup is the same. MRI, head, orbit, gadolinium, fat suppression, and MR venogram, and spinal tap. Before you let this person leave the clinic, however, who has bilateral disc edema, we have to check something in the clinic. What
Blood
other thing
pressure.
are the blood pressure? And you're going to have a malignant hypertension crisis here in this country too. All right, so if the blood pressure is elevated over 180, where should they go? To do what? How fast should you reduce their blood pressure? Slowly. How slowly? How slowly should we go? Give them an oral agent, or they need intravenous?
Intravenous.
They have to have intravenous. And in our country, they're going to get admitted. So we admit hypertension grade 4 disc edema. So for ophthalmologists, there are 4 stages of hypertension in the retina. Stage 1, arterial narrowing. Don't admit that. Stage 2, AV nicking, because the artery and the vein cross. The arteriosclerosis presses on the vein, causes AV nicking. That's stage 2. We don't admit that. Stage 3, the blood vessel broke open, blood come out. Exudate, fluid, edema. That one needs to come to the hospital. And stage 4 is optic disc edema. So stage 4, hypertensive retinopathy, admit to the hospital. For what? Lowering the blood pressure with an intravenous titratable agent that's usually labetalol or nitroprusside or something intravenous. And we only reduce the blood pressure 25% in the first 8 hours. That's not your job, right? That hospitalist or medicine is doing this, right? Okay. What if you don't check the blood pressure? You'll be doing a CT and an MRI on someone who needs to have their blood pressure lowered. So the very first thing we got to do is check their blood pressure. Yes? Okay, so normal autoregulatory curve over a wide range of pressures, you have very flat cerebral blood flow. But if you have chronic hypertension, your curve is shifted to the right, like this. And therefore, if you lower this person's blood pressure too quickly, even if you think it's in the normal range, you actually put them on the steep part of this curve. And if you put this hypertensive person right here, you stroke them. So do not lower the blood pressure too quickly in hypertensive emergency. What defines emergency in hypertension versus urgency in hypertension? End organ damage. The end organs are you guys, brain, that's TIA, stroke, and us, that's hypertension, but grade 3 or grade 4, and kidney and heart. So kidney, heart, brain, eye. But the dividing line in the eye is the retina and the optic disc. So before this person with true disc edema leaves the clinic, we must check their what? Check their blood pressure and make sure it's not target end organ damage. That is hypertensive retinopathy 4. If it's to you guys, TIA or stroke, all those need to be admitted. Please don't lower their blood pressure too quickly because the autoregulatory curve for hypertensive chronic is shifted to the right. And if you lower it too quickly, more than 25% in the first hour, you're the villain of this story. If you send it to the ER, they might give an oral agent and stroke the person. And they'll call you back and they'll say, hey, the person you sent, they're worse after I lowered their blood pressure. How fast did you lower it? Oh, I just gave them this oral agent. You have no idea what that oral agent is going to do to a patient who's naive to that drug. You need a titratable intravenous agent so that we can turn it off. If their blood pressure starts to drop, you just turn it off. It's the labetalol drug, just turn it off. You understand what I've said about this? All right. If it's true disc edema and it's unilateral, you need to know what the most common cause of unilateral and bilateral optic disc edema is. So, in a young person, a 20-year-old, female, acute, unilateral, loss of vision, pain with eye movement, relative afferent pupillary defect, slightly swollen nerve, other eyes normal. What's the diagnosis? Optic neuritis. What's the most common cause? Multiple sclerosis. Admit. What are you looking for? MR, head, orbit, gadolinium. We're looking for enhancement of the nerve. once you see the enhancement, that's not macular edema anymore. That's optic neuritis. So my dad would say, if it quacks like a duck and flies like a duck and looks like a duck, it's a duck. You need to know what a duck looks like. The problem is your duck here in Kuwait can look like any kind of duck. Why? Because 70% of your population is from somewhere else, and 30% is Kuwait. Yes? Is that right? Is that your number? And your non-Kuwaiti population comes from everywhere on this planet. Yes? So, if it's brown person, you got to worry about non-MS things. That's neuromyelitis optica and MOG, myelin oligodendrocytic glycoprotein. You also got to worry about syphilis and sarcoidosis and then tuberculosis. Why? Because those people that are here are coming from endemic areas where you don't have those diseases or they have it way more than you. You understand how your non-Kuwaiti population has a different endemic risk than your Kuwaiti population? For multiple sclerosis, this is the equator. Where is the MS on our planet? The cold places. So between 30 and 50 degrees northern latitude. So if you just draw a line across the northern hemisphere, that's Canada, the United States, all the way across the Atlantic Ocean to Europe, Scandinavia, Russia, all of that top half of our planet is MS land. Yes? However, weirdly, the exact same latitude in the southern hemisphere also has multiple sclerosis. Argentina, Chile, all the way across the ocean to Africa, but not anywhere in Africa, only South Africa. And then all the way across the ocean, skip Indian Ocean, skip Malaysia, skip all those places. And the next country you hit is Australia, and the next country after that, New Zealand. You understand what I've said? MS has a geographic predilection. Now, it's not known why that is. Maybe it's vitamin D and sun or genetics. We don't know. But some percentage of this expat population is from this hemisphere, in this latitude. So you're Americans, you're Canadians, you're Europeans, you're all are MSville, but also you're South Americans, Argentina, you're Chileans, you're South Africans, you're Australians, and you're New Zealanders. And weirdly, because you don't have alcohol here, you probably don't know that the wine countries are the same latitude. The grape for wine, it only grows in this latitude here. There are no equatorial wine countries. There's no wine of the Congo. There's no wine of Indonesia. They have to make wine out of stuff that shouldn't be made anymore. Okay. And in the southern hemisphere, Argentinian Malbec, yes? South African Chenin Blanc, Australian Shiraz, New Zealand Southern. So if they have crummy wine, you better be thinking NMO or MOG or some other thing. And weirdly, all these places here have tuberculosis. So the places that have the MS don't actually have the TB. So you shouldn't be really thinking about TB in your Canadian expat guy who works for oil and gas. That's not the guy that has the TB. It's your guest population workers from endemic areas: Bangladesh, India, China, Indonesia. Yes? So because you have this weird thing, you need to practice global ophthalmology. That's super weird. And your incidence in Kuwait is, as a result, is mixed. You're between our hemispheres now. Now you have a mixed race population, and that means you have to be a global neuro-ophthalmologist. That's so weird. You have to know about tuberculosis, syphilis, MOG, NMO, multiple sclerosis, right? Because like just walking down the hallway of your hospital here, it's like, wow, the whole world is here. Yes, the whole world is here. All right. Do you understand everything I've told you about optic disc edema?
Yes. Can we discuss nuclear and supranuclear disorders?
What's that?
Can we discuss nuclear and supranuclear disorders?
Supranuclear and nuclear. Okay, sure.
Thank you.
All right. So what does supranuclear mean? Supra. What is supra? Above. And what is nuclear? That's the nucleus. There are three nuclei of the three oculomotor nerves. What are they? Three, four, six. And then there's infranuclear. What does infranuclear mean? Below. It could be the nerve, it could be the muscle, it could be the junction. Neuromuscular junction. Yes? The most common neuromuscular junction disease that we see is myasthenia. The most common muscle disease that we see is thyroid eye disease. The most common nerves are 3, 4, and 6. But of those, 6 is probably the most common. And so now we're just going to be talking about supranuclear, right? Supranuclear. All right. So when you want to look to the right, I just want to look over there. How does that happen? Yeah, but that supranuclear first. I want to tell myself to look to the right. Saccade. So it depends whether it's saccade or pursuit. So if I want to saccade to the right, cortex has to do that. Which cortex is telling me to fire? The frontal eye field for saccade. And if it's I want to look to the right, which frontal eye field is firing? Is it the right or the left? So I want to look to the left, let's say. Which frontal eye field will fire? I want to look to the left. The contralateral. So you need to know that the saccade pathway, if I want to look to the left, my right frontal lobe has to fire first. That's supranuclear, above the nucleus. It's going to tell two nuclei to look, make my eyes go to the left. In the right eye, which muscle is firing? I want to look to my left, right medial rectus, and I got to fire my left eye, left lateral rectus. So if I want to look to the left, left lateral rectus, right medial rectus have to fire. And they have to fire at the same time, with the same speed, the same amplitude. We have to get both eyes onto the target exactly at the same time. And that's why you have supranuclear control. Because if you just let the eyes do whatever the hell they want to do, then one guy will be lazy. So yoke the two muscles together. Yoke. They're connected by a neurologic bridge. That bridge is called a yoke. So they are yoked together. And you know the name of the law that says these two yoke muscles will receive the same innervation, equal innervation.
Sharing.
Which is it, herring or sharing?
Sharing.
This one is called herring. So the other one is called sharing. So in the Herring's law, the two yoke muscles, to look to the left, right medial rectus and left lateral rectus have to be told to go together, and you must turn off muscles that go in the other direction. So there's reciprocal inhibition. We have to turn off the muscles that go to the right. We have to turn on the muscles that go to the left. Both the turning on and the turning off are supranuclear. So the supranuclear, your cortex, has to tell your nuclei to fire together and not fire together. That is, fire together, Herring's law. Don't fire together, Sherrington's law. You have to turn on and turn off your nucleus. You understand what the purpose of the supranuclear system is? All right, so we're doing this saccade to the left. My left, go to the left, right frontal lobe tells right medial rectus and left lateral rectus to fire at the same time. So how does it do that? Well, there's a neurogenic yoke between the two nuclei. So what is the nuclei for 6? Where did that guy live? In the pons. So you got midbrain and you got pons. So in the pons, number 6, he has to be yoked to 3, the medial rectus. What is the name of this yoke? Medial longitudinal facility. So the 6th nerve nucleus is the final common pathway from a nuclear level to tell the infranuclear 6th and the infranuclear 3rd to fire at the same time. So if I want to saccade my left, right frontal lobe, down to parapontine reticular formation and to 6th nerve nucleus, through medial longitudinal fasciculus, the yoke muscle, Herring's law, look to the left. You got this whole thing down now.
Yeah.
So that is how I look to the left. However, I can make my eyes look to the left without the cortex by just making my head go like this. Because the vestibular system, the horizontal canal, remember that? The semicircular canal? So just me going like this, I have to make counter rotation, otherwise you guys will be moving all over the place. Because I can just look at you and still do this, and I'm fine. That is a vestibular ocular reflex. I don't need to tell my brain to do anything. I can just make my head go right like this, and you're just totally sitting in your seat. What would happen if I didn't have a VOR? Every time I did this, the whole world. So like right now, you're shaking your head like this because you understand, or you're not? Yes? When you're shaking your head like this, am I moving?
No.
No. Why not? Your VOR is compensating for that head rotation. If you didn't have that, every time you agreed with me, I would move. But I'm not, because you're VOR. Yes? So that VOR, the vestibular ocular reflex, means your semicircular canal, the vestibular system, talks directly to the sixth nerve nucleus and says, hey man, the head's rotating, counter roll the other direction so that Dr. Lee doesn't move off stage. You understand why you need this? And what that means is the way to tell the difference between supranuclear and infranuclear is we can rotate the person's head. What is the name of that passive rotation of the head to move the eyes? Like this. A doll's head. Doll's head. So that is an oculocephalic maneuver, the doll's head. So if you rotate a doll, their eyes will move because they don't have no VOR. However, if you rotate me, I do have a VOR. And so let's say I say to you, I can't look to the left. And you want to know if that's supranuclear or infranuclear. How would you test me? You just take my head and go like this. And what if my eyes rotated passively over there? That means everything from the nucleus down to the neuromuscular junction and the muscle is intact. It means the eye can look to the left, but something's wrong with the supranuclear control mechanism. So to tell the difference between supranuclear and infranuclear and nuclear palsies, you just do this doll's head maneuver. That is correct. Because if you can overcome it with the doll's head maneuver, that means there's nothing wrong with their nucleus, there's nothing wrong with their nerve, there's nothing wrong with their neuromuscular junction, there's nothing wrong with their muscle. And yet you see how many times the neurology service on my own hospital comes and orders myasthenia tests on someone who we already said the doll's head maneuver overcame the palsy. If the doll's head maneuver overcame the palsy, that can't possibly be myasthenia gravis, because doll's head cannot overcome myasthenia. But they insist on ordering the myasthenia lab anyway, when they should be scanning the person, and they're looking in the wrong place. If it's a supranuclear, cortex, not brainstem. Yes? Okay. Because it's my right frontal eye field, if I have an irritative lesion, seizure, I got a seizure in my right frontal cortex, it'll drive the eyes. Which direction will the eyes be driven? If it's an irritative focus, I'll have a gaze preference to the left. So you go up to the room and the person is looking over to the left. That could be irritative on the right, but it could be they're looking to the left because they can't look to the right. And because that's the contralateral, will that be on the left or the right frontal eye field if I can't saccade to the right? That'll be on the left. So you need to know the difference between a destructive lesion and an irritative lesion. Okay, the right frontal lobe tells you to look to the left. You got that part? It's contralateral. If you have an irritative lesion, a seizure focus, it'll drive the eyes which direction, right or left? If it's right frontal lobe.
Left.
Drive it to the left. So you'll have a gaze preference to the left if you have a seizure in your right frontal cortex. However, if it's a destructive lesion on the right, then you can't look to the
Left.
and your eyes will go to the. So if you are shown a picture of the gaze and the person has a gaze preference to the left And the question is, they cannot saccade to the right. They have a right saccadic horizontal gaze palsy to the right. Is it an irritative destruction on the right or the left? What's the correct answer? If it's irritative and they have a gaze preference to the left.
Right.
However, if the question is it a destructive lesion?
The same would be left. To the right. So if it's left, to the left.
If it's to the left,
So it's the left.
you can't look to the,
Right.
is that destructive lesion on the right or the left?
Left.
That's on the left. However, it's irritative, it's on the
Right.
contralateral side. Do you understand everything I've told you about this frontal eye field thing? So you go to the floor and there's this person and you gaze preference to the left. The first thing you're going to do is to make sure that it is supranuclear. Once you've decided it's supranuclear, that means for saccade, frontal eye field. For pursuit, it's ipsilateral. That's a huge problem for chess, okay? So if they can pursue, that's ipsilateral. If it's saccade, that's contralateral. And that is parieto-occipital temporal junction for the pursuit. So it's ipsilateral parieto-occipital temporal lobe for pursuit. It's contralateral frontal eye field, and then the whole irritative versus destructive thing again. If it's destructive and it's frontal eye field, they won't be able to look to the ipsilateral or contralateral gaze. If it's destructive lesion on the right, I won't be able to look to the
To the contralateral.
okay, frontal eye field. It controls the ipsilateral or contralateral saccade. Contralateral. So if I damage the right frontal lobe, I won't be able to look to the right or to the left. I won't be able to look to the left. And therefore, your eyes will be preferring to look. However, it's an irritative lesion. It's a seizure. The eyes will be turned to the left. You sure you got this?
Yes, definitely.
All right. So supranuclear. Okay, what are the most common cause of supranuclear? The most common cause is seizure in the acute setting and stroke. But it can be anything. It doesn't tell you what it is. It just tells you where it is. Location, location, location. It only tells you where. Could it be demyelinating? Yes, but it's so unlikely. Okay? It's usually stroke, tumor, seizure. That's usually. Okay, you got this horizontal thing down. The vertical. The vertical requires both frontal eye fields for saccade. So both frontal eye. So if you have a brainstem midbrain interruption of the supranuclear, the lesion is here somewhere. What would you call a progressive and supranuclear palsy? What do you say? Yeah, that's what it's called. A progressive supranuclear palsy is called PSP. So the person comes to you in neurology clinic. And the patient's family says they have Parkinson's, but they haven't responded well to this levodopa carbidopa. That's already a big red flag. So Parkinson can cause upgaze, but what it cannot cause is downgaze. So the very first thing you're going to do in this Parkinsonism patient who's complaining about something wrong with their eye movement is you're going to have them to look down. And if they can't look down, you got to do this test on them. What are you going to do on them? What's the name of that thing? VOR, oculocephalic maneuver. The doll's head maneuver. If the doll's head maneuver, the eye does go down. Is that nuclear or supranuclear? It's supranuclear. And if it's progressive and a supranuclear palsy, what's the diagnosis? PSP. Progressive supranuclear palsy. And what that did was it just changed the diagnosis for atypical Parkinson's disease to PSP. Now, we don't have good treatments, but it changes their prognosis. They might spend their time differently if they do that. Yes? So, supranuclear. The most common degenerative chronic is PSP, progressive supranuclear palsy. The most common acute supranuclear palsies are stroke and seizure. The most common subacute is tumor. It doesn't tell you where it is. So that means all of these patients have to be imaged. And what is the imaging finding of the progressive supranuclear palsy? Like a bird sign? What's the name of that bird? Hummingbird. You guys have hummingbirds in Kuwait? No? Okay, a hummingbird is a super small bird. He's super small. He got a really long nose like this because he want to stick his nose inside of this flower. So he's trying to get down here to the neck. So this guy is a hummingbird. So we have a normal midbrain and pons, big belly, but when you have midbrain atrophy, hummingbird. You see the hummingbird? Hummingbird sign, progressive supranuclear palsy. By the time you see the hummingbird, it's so late. But you need to know it for the test. Okay? Do not rely upon the hummingbird for anything. Okay? Way better to do a doll's head on every Parkinson's patient who says they have eye problems. The most common eye problems in Parkinson patients are dry eye. Why do they have dry eye? They have poor blinking. Why aren't they blinking? Is it nuclear or infranuclear or supranuclear? It's supranuclear because their nigra isn't firing properly because they don't have enough dopamine. So they're like not blinking, get dry eye, and they have convergence insufficiency. What is convergence? When your two eyes converge on a target, you have to make your eyes cross to look at something in near. Convergence. Why do they have that? Is that nuclear, infranuclear, or supranuclear? That's also. So the convergence center lives in your thalamomesencephalic junction. Nothing wrong with your third. So the Parkinson patient says, I have double, it's only at near. You do a uncover test, their eye is exotropic, but only at near because they cannot converge. So the most common cause of monocular diplopia in a Parkinson patient is dry eye, because decreased blinking, that's supranuclear, and convergence insufficiency at near, binocular diplopia, only at near. Binocular means you cover either eye, it goes away. And their eye movement is fine. So in both patients, they're going to be complaining about diplopia. But when you do the eye movement, you see nothing. You're like, I don't know why. So the first thing you got to do, order of operations for every diplopia patient in Parkinson's disease is it one eye or two eye? If I cover the eye, doesn't make it go away. If they cover their left eye, it's still there. That's monocular. That's dry eye. That's not enough blinking. That has nothing to do with you. That's dryness. That doesn't need an MRI. Okay? If it's two eye thing, is it distance and near? If it's near, you do a cover, it goes away, cover the other eye goes away, and what you see when they look at something in near is their eye drifts out. Exotropia, because their convergence is insufficient. That's supranuclear. A lot of people have this. I have this because I'm old. So old people, they just can't converge, and also they can't accommodate. We have to wear bifocals. So we have both accommodative insufficiency and convergence insufficiency with age, but Parkinson's patients just get it way sooner because they're dopamine size. But if they're complaining about their eyes don't move and they have Parkinsonism, you have to tell them to look. And then if it can't look down, you're going to do a. And if the doll's head overcomes it, is that supranuclear or infranuclear? Super. And the most common cause of progressive supranuclear palsy in a Parkinson patient is progressive supranuclear palsy, PSP. You with me on everything I've just told you about supranuclear?
Yes.
All right, continue. You can have a break. How much of a break do you want? It's your day. This day is for you. 10 minutes? 10 minutes. If you want to take longer, it's fine. I will not be upset. All right, 10 minutes. I'll just stand up.
Thank you so much.
Hello.
ان شاء الله كمل
So that is a